just to get started here, my name is Kelsey Sukavati, and I just wanted to welcome you all to tonight's IPMS New Practitioners Group presentation. We are looking forward to this session pertaining to coding and billing presented by Dr. Ed. We are recording tonight's coding session, and we'll make it available to members as well as a copy of tonight's slides. And additionally, if you have any questions, please type that into the chat screen, and Dr. Ed will take the questions at the end of the presentation. So Dr. Ed has been involved with the IPMS for many years. He has been a former board member, president of the IPMS, director of the Insurance Advisory Committee, and CIC representative. Nationally, he has been the chair of the APMA CIC committee. He has also served on the APMA Health Policy and Practice Committee for the last 13 years and as chair of that committee for the past 2 years. Dr. Ed has lectured on coding and policy locally, regionally, and nationally. Currently, Dr. Ed is retired from private practice after almost 39 years. He is a certified coder with certification in surgical foot and ankle coding with the American Academy of Professional Coders. He also currently serves as the IPMS insurance consultant. In this role, he assists the IPMS members that have specific coding or insurance issues. Tonight's webinar focuses on navigating the modifier maze. Coding with the modifiers and using modifiers properly can make a difference in having a claim paid or denied. This webinar will be providing details to know exactly how and when to use the most commonly utilized modifiers in coding for podiatric services. This includes global period modifiers, NCCI modifiers, DME modifiers, and more. Dr. Ed will present for the first 40 minutes, and then we will conclude with a Q&A session. So let's all welcome Dr. Ed.
Thank you, everybody. It's good to have you here on a Tuesday night. I'm sure we've all got other things you'd rather be doing, but hey, let's get educated a little bit. Modifiers have been something I've been interested in for a lot of years, and I've spent a lot of time studying modifiers. Now, when I put this presentation together, what I ended up doing was providing a lot of detail on these slides. But I am not going to talk about all the details on the slides. I just wanted you to have that available for your reference and maybe for a deeper understanding of some of these modifiers. But literally, there are hundreds and hundreds of modifiers that are out there. And what I'm going to talk about tonight is the ones that are applicable to podiatry. And I think I'm going to end up covering the majority of what podiatrists do use in their day-to-day practice. Even if you don't do your own coding, you still need to have an understanding of some of the rules and regulations regarding these modifiers so that your documentation can reflect what it needs to in order to properly use modifiers. Not using modifiers when it's required will get the code or claim denied, but also inappropriate use of modifiers, meaning using them when they're not supposed to be used, can also get claims or line items denied. Something that's important here is that denials based on improper coding become provider liability, meaning you can't charge the patient. So it behooves us to make sure that we're using the proper modifier when required. And I'll skip through some of these slides, and as we go through the presentation, there's some that I'll read, others that I won't, only because, again, I put details in there so that the members that are attending this webinar that will have access to this slide deck can have a lot of information, even if we don't review it during this presentation today. Of course, we have to have a conflict of interest disclosure, and I do, as mentioned, work as an IPMS insurance consultant, and there's our CPT disclaimer there. So, why modifiers? Well, this is the strict definition of what modifiers are all about. They're code enhancers. In this day and age, when computers are processing claims and not people, computers have edit programs that are based on denying codes when they can, and we're all familiar with denials. But modifiers can bypass edits when appropriate to secure fewer denials and to get paid for the things that we do. There are two groups of modifiers, level 1 and level 2. This is not important other than that CPT has level 1 modifiers and CMS has a level 2 modifiers. And the difference between those is that the level 1 are your numeric modifiers, whereas your level 2 are digits with letters in them. And we're all familiar with both groups. Maybe we've never thought about breaking them down in this way. Now, there are functions for modifiers, and the functional modifiers affect pricing, and those are important. But the informational modifiers, which are often required, do not affect the pricing. They're, again, for information only. But the general rule of thumb is that always put the pricing modifier in the first position. If you're using multiple modifiers, always put the pricing modifier in the first position, because if that isn't there when it's supposed to be, the line item will deny, even if you have the pricing modifier listed somewhere in there. And again, we'll talk about these a little bit more as we get into more details. Now, we can further subdivide modifiers into anatomic modifiers, global surgery modifiers, and other modifiers. And again, not important, but just for information alone. So because global period affects a lot of modifier usage, I want to explain what global periods are all about. Everybody knows that, you know, when we do procedures, they're going to have 0, 10, or 90-day global periods as a general rule. But the 90-day global period really accounts for 92 days because it starts the day before the surgery and includes the day of the surgery and then the 90 days after the surgery. And the 10-day global periods start the day of surgery and continue 10 days after the surgical procedure. So it ends up being 11 days for a 10-day global period. And the 0-day global includes post-op care on that date of the procedure. So even though it says 0, you still have the 1 day. A lot of times we'll see these other designations for global periods like the ZZC, and that means that code is related to another procedure. And typically we think of the add-on codes, okay, that they're related to the main code. And so their global is going to be what the main global is. And the XXX has no global periods. And this applies to like X-rays or E&M codes. There's just no global to that. Not 0, no global. And then there's a difference between the two because the 0 has global for that day of the procedure. And the YYY is carrier determined. And usually these are for the unlisted procedure codes, but there's other codes that do get involved in that category. So let's go ahead and start with these numeric modifiers. And the first one is modifier 22, which is increased procedural service. Now, what that means is that the surgery took more time, it was more difficult, that there were situations involved with the surgery that required increased intensity, increased time, more technically difficult, etc. And if you encounter a case like that, you know, for instance, these procedures usually take me 45 minutes. This time it took me an hour and a half because of these issues, then you can bill for that additional time. And these are some of the reasons that might justify the use of a 22 modifier. And again, we don't need to go through these, but you can refer back to this if you run into one of those situations. What we've always recommended is that if you submit a claim with a 22 modifier, what we recommend is that you initially submit it without the modifier, just the code itself. And once you get paid for it, resubmit it with the 25 modifier for a review of that claim. And the reason is, if you submit it with the 22 modifier, initially, you're going to be waiting a long time before you get paid because these have to be manually reviewed. Okay, the next modifier, which is an easy one, is modifier 24. And this is one of those global period modifiers. And it's unrelated E&M during the post-op period. So you're seeing the patient for post-operative care, but you're also doing something that's not related to the surgery on a condition that the patient developed, and this is the way you would report it. You'd evaluate and manage the problem and report the E&M code and put a 24 modifier telling the payer that this is not related to the surgery that was done and should be payable. Now, one of the big ones on hand is that we're all dealing with is a 25 modifier. This one, along with 59, probably gives us the biggest headaches in the medical world as far as modifiers are concerned. And this is also very misunderstood. When I've reviewed charting on practices that have had claim denied with a 25 modifier, oftentimes what we see is that the documentation did not support the 25 modifier. And the documentation must show why the service was separate and distinct from the procedure that was performed on the same day. So if you do an E&M and a procedure on the same day, the E&M needs that 25 modifier. And if your documentation is appropriate, you can get paid for this. Now, this is used for those when you're doing a minor procedure. So you do a minor procedure and you're doing a separate E&M. And that minor procedure would have a 0 or 10-day global period. Now, CPT, CMS, and everybody else in the world says that every procedure code has a mini E&M built into it, which is inherent in that, which is true. And when you use the 25 modifier, you're saying that this is completely separate from the E&M that's built into the procedure code. So CMS, for instance, will say, NCCI will say that E&M services on the same date as a minor surgical procedure are included in the payment for that procedure. And that's why we see a lot of these codes denied on the front end, when you first submit a claim. And per NCCI, the decision to perform a minor surgical procedure is included in the payment for the minor surgical procedure. And all that's true, but it's not applicable if the patient presents with a new problem, even during the global period. So you've done a bunion correction, they come in with heel pain, you're golden as long as your documentation can support that during the global period that you're working up a new problem. Now, sometimes we have to reevaluate a current problem when there's a change in conditions. So let's say you're doing wound care. Patients coming in every week, everything's going well, they're healing slowly as usual, but they are healing. They come in on one visit and all of a sudden they got cellulitis, they've got purulence, they got more necrotic tissue. You need to reevaluate that, see what's going on. So you can charge for your debridement, but you can also charge for the E&M with a 25 modifier. The 25 modifier does not require a separate diagnosis. And again, as everybody's heard, we don't use the E&M with 25 if the patient was scheduled for that procedure. So if you tell the procedure, I'll see you back next week, we'll do after you complete the course of antibiotics, and we'll do the P&A procedure. Or we'll inject your heel next time you come back. Well, if that's what the patient's scheduled for, you cannot charge an E&M for that. Okay, now everybody knows that E&M, what it stands for, but it is the management that may qualify for the reimbursement if a procedure is chosen as the treatment. And hence you can use this argument when appealing a claim. Of the slides I have on this modifier, this is the most important one, and I think it's worthy of reading. The plan must exhibit a separate paragraph. That's in your SOAP note now. The plan must exhibit a separate paragraph explaining the discussion with the patient regarding their diagnosis, potential etiologies, treatment options for that diagnosis, the risks and benefits of the various treatment options, advantages and disadvantages of those options, how to prevent reoccurrence, answering the patient's questions, and any discussion that takes place regarding the treatment option, and then whatever is chosen as the option. But this must be documented, and we prefer or recommend a separate paragraph to make it easier when you have to submit your notes for consideration of payment for that it'll be distinct and separate, and it'll be easier for a reviewer or auditor to look at that. Now, upon appeal, this is a slide we're not going to read, but if you have to appeal a denied claim from a 25 modifier on an E&M service, these are some of the arguments that you're going to want to make. Now, we'll move on to modifier 26, which is defined as professional component. which is what the physician that's interpreting a diagnostic test would use for his portion of that code only. So these diagnostic tests have a technical component and a professional component. The professional component is the interpretation of the reading, which has to have a written report. And so they're differentiated between the technical component, the professional component, depending upon which part that you or that physician is doing. And this is used mainly for diagnostic procedures. And by the way, the technical component does comprise the majority of what's reimbursed for this. Now, if like for x-rays, we take our own x-rays in the office, we interpret them, and we write a short note on the results of that x-ray. So when you do the entire code, you do not need any of these modifiers. And I think, okay, this is a modifier 50. So we'll move on here to modifier 50, which is bilateral procedure. Now, this is used to report procedures performed on both sides of the patient's body. And the CPT code either indicates or specifies that it's unilateral. For instance, if you do a bunionectomy is singular, just like a hammer toe code 28285 is singular. And so there's no bilateral component to that. So it indicates that it's a unilateral procedure. So let's say you do a bunion on both feet. The best option would be to use on one line on the claim, put the CPT code down to 2829, whatever, and use the bilateral modifier -50. Now, we don't use those on skin procedures because skin is one organ, so there's no bilateral or unilateral to that. Also, it's not used for radiology procedures or diagnostic procedures either. And here's an example, as I mentioned before. Now, when you do this on one line, you're going to want to double your fee, because the rule of thumb is that you'll get paid 150% of the fee schedule, whatever that might be. And so most people just bill twice their normal fee. Okay, and here's another example of where the code says bilateral. And so when you do this bilateral, the 93922, the limited or complete arterial study of the non-invasive vascular testing, you do not use the bilateral modifier because the definition of the code states that it's bilateral. And if you end up doing this unilateral, you have to use another modifier to let them know that you did less than what the code definition was. Now let's look at multiple procedures, modifier 51. Modifier 51 is not one that is used very often, and the reason is because the computers at the insurance companies, including Medicare, is going to put 51 modifier on anything more than the primary procedure. And so that's why although you can use it, it's not required. The computers are automatically going to do it. One of the reasons they do that is so they can apply the multiple procedure reduction rule that we're all familiar with, where you get 100% of the fee schedule for the first procedure and 50% of the fee schedule for the second and subsequent procedure. Now, when you do 6 or more, technically from Medicare, they say that they want to manually review that, meaning if you do 6 or more procedures, they're going to want the op report before they end up paying those additional codes. Now, one thing that's important with this is that this multiple procedure reduction rule is that it does not apply to all codes. It applies to most procedure codes, but not all of them. And that's why, if you've ever noticed, when you do like routine foot care, you do calluses and nail debridement, that you'll get paid 100% of the fee schedule for the nail debridement, even though it's the second procedure. And that's because it's exempt from that, just like X-rays would be exempt from that. So how do you know? Well, listen, most codes, the second procedure is applicable for that procedure reduction. And so, and we're used to seeing that anyway on our EOBs. No matter what you charge, you're gonna get 50% of the fee schedule for that second, third, fourth procedure, et cetera. And we've all learned to live with that. Now, reduced services is one where you only did part of what CPT defined for that procedure. And this is an example as metatarsectomy. That means the entire metatarsal. And so let's say someone has osteomyelitis in the first metatarsal, and you remove the distal 3/4 or whatever of that metatarsal because you want to preserve the metatarsal cuneiform articulation for the peroneus longus or tibialis anterior tendon insertion and the function of those tendons. So you end up taking 3/4 of the metatarsal out. The metatarsal is clean at that level. And so you have a couple of choices in how you can do this. You can do the reduced service modifier, which is modifier 52, since you only did 3/4 of it, not the whole metatarsal, or you can use an alternate code, complete excision of first met head, and that way you can get paid adequately for that procedure. Okay, modifier 53, discontinued procedure. Now, this is something that's rarely utilized for most surgeons, but it is something that can come up periodically. So you meet the patient at the hospital that day for the surgery, you scrub, you get into the OR, the patient has had induction of anesthesia, and all of a sudden an emergency situation happens and the anesthesiologist has to cancel the case. And in that case, you would report whatever procedure you were intending to do with the 53 modifier. And you'll get paid something, usually around 25%-ish, but you're likely to have a hassle with this and have to undergo some appeals, et cetera. But it's doable. And again, since it's rare, it's probably not something we have to worry about very much. Now, the inappropriate use of this is if you get in the room and the patient hasn't been induced by the anesthesiologist, then you're just out of luck for that day as far as billing with a 53 modifier. You could potentially bill a hospital visit, outpatient visit with an E&M code, and at least get something for the time and scheduling out your morning. But again, if it's done after induction of anesthesia, then we definitely want to use the 53 modifier. Now, I put these codes in there for the sake of completeness for this deck, slide deck here. And this is something that rarely happens in our profession, but it does happen. Someone does the surgery and someone else does the post-operative management. So you've got a patient needs a procedure. So your friend down the street might do the surgical procedure for you because you're not trained to do it or whatever the reason might be, but he turns the case back over to you to do all the post-operative care. And these are the modifiers that you would use. And this is how the breakdown works out at the bottom, is that the surgeon would get about 79% of the fee schedule for that. And for you to do the post-operative management only, you'll get about 21%. And again, nothing we have to be overly concerned about since this is something that's rarely used. Now, modifier 57 is the equivalent of modifier 25 with some differences. But this is applied to your procedures, your major surgical procedures with a 90-day global. Now, when you do an E&M on a visit that determines the decision to perform the major surgery, and you do the surgery that day or the next day, then you can bill and get paid for the E&M as long as you append the 57 modifier on it, and you'll also get paid for the surgical procedure done that day or the next day. Now, it's not used when we're doing minor procedures with 0 to 10-day global, and it's also not used if you did the visit, the E&M visit, 2 or more days before the major surgery. So let's say you get called into the hospital to see a patient for an ankle fracture, and there's swelling, it's just out of control. You know you're not going to be doing surgery on them that day or the next day. So they're there with compression dressings, diuretics, et cetera, to get that edema reduced to a point where you can do the surgery. So you do the E&M one day, and 2 or 3 days later, you do the surgery. You do not need to put the 57 modifier on the E&M code because, again, that's for the day before or the day of the surgery. And now I put this example in here with some questions just to kind of get your mind working a little bit, because I know this these modifiers is not real exciting lecture material, but it's a very necessary a bunch of information that we need to have to get by in our daily practices. So this example, a patient is seen early in the year for a painful bunion and decides to have a surgical correction. But because of where the person works, they have to make arrangements and can't have the surgery done for 5 months until July. So the patient returns 2 days before the surgery to review the surgery because they have forgotten the details of what's involved or what's involved in the recovery. Can I walk on it? How long is it going to take to heal? How much pain is there going to be? Blah, 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 and all that. And they return 2 days before the surgery. So is the visit billable? And my opinion is that yes, it is, because and especially if you base this on time and not medical decision making, because medical decision making has already been made to perform the surgery, and you're just using time, which is fine when choosing an E&M code. Now, do you use modifier 57? Absolutely not, because that is if you do the E&M the day of or the day before the surgery and not 2 days before the surgery, like this question asks. So let's use the same example, but say the patient returns 1 day before the surgery to review, as you know, for the same reasons. Is this visit billable, and can you use modifier 57? Well, is the visit billable? It's done the day before, and if we look at the 90-day global, it includes what you do the day before. Okay, so is the visit billable? No, not the day before. Can you use modifier 57? No, because modifier 57 is defined as decision for surgery. The patient has already decided to have surgery. You've agreed. You've decided that as well. So in the second example there, you cannot bill for that visit. That's just a gimme, based on the definitions of the global and modifier 57. So if we go to modifier 58, this is something that we tend to use off and on. So it's not rare, but it's not real common. Staged or related procedure by the same physician during the post-op period. Now, one of the important points on modifier 58 is that it does reset the global period. And when it does that, though, it does pay for 100% of the fee schedule for the code that you're using. So when do we use modifier 58? Okay, you're in a global period, and you'll be doing an additional procedure that was planned prospectively. Let's say you have someone with a major infection, osteo or deep abscess. You take them to the OR, you drain it, you remove the bone, whatever you do, but you leave the wound open. 2 or 3 days later, you go back and close the wound. So that, and you knew you were going to do that. That means you prospectively planned that. And that information should be in the chart, in your operative report that you're planning on, having to do that. And you might even say that, and depending upon, the status of the infection, I may have to go in and remove more bone, etc., which is the second part of the definition of modifier 58, more extensive than the original procedure. Okay, so you're taking out more bone. Another example of that, let's say someone had a gangrenous second toe on the distal aspect. So you have the patient in the OR, and you do an amputation of the toe through the proximal joint. Several days later, the patient's starting to get dusty changes, some gangrenous changes in the proximal part of the toe that's left, and you have to go in there and remove the rest of the toe at the MTP joint level. That's another example where you use a 58 modifier on that second procedure and how it fits into the definition of being a more extensive procedure than the original procedure. And then the other definition, and one that's sometimes misunderstood, especially by newer practitioners, is for a surgical procedure following a diagnostic procedure. It's like, what does this mean? Okay, let's say you have a patient, I'll use an example, a patient that has chronic ankle pain, and you've not been able to figure out what it is. The x-rays look good, the examination, there's nothing you can really pinpoint as to what's going on. So you tell the patient, we'll take you to the OR, I'll do a scope on your ankle, we'll see what the heck's going on and see if we can fix it. So you get in the OR, you scope the patient, and you found out that they have an OCD. Now you open up the patient and you repair the OCD. You can bill for both procedures. The OCD repair would have the 58 modifier, but you also bill for the arthroscopic examination and get paid for the diagnostic procedure that determined the need to do the surgical procedure that you ended up doing, okay? Now, the 58 modifier is not used to treat complications requiring a trip to the OR. That's the definition of modifier 78, which we'll talk about in just a little bit. But I'll have to tell you, there's going to be some overlap at times, and you'll have a choice. Do I use 58 or do I use 78? Now, a modifier 59, this is probably the most used modifier in podiatry, dermatology, and other professions. And it's also the one that's most abused. Distinct procedural service. So when we're doing more than one procedure, we have to look at, are we unbundling something from that main procedure and trying to bill for it, or is it legitimately a distinct procedural service? National Correct Coding Initiative was developed to address this problem, and they have what's called column 1 and column 2 codes. The column 1 code is a comprehensive procedure, and the column 2 is the component procedure. So for instance, like with the bunion procedure, the capsulotomy is included. The tenotomy of the adductor tendon is included. The sesamoidectomy, if you do, is included. And if you unbundle these, you're going to want to put the 59 modifier, but only if it's appropriate. Modifier 59 is modifier of last resort. If there's other modifiers that you can use, it is recommended that you use those other modifiers. And those and the most appropriate ones that we sometimes can use is the anatomic modifiers or the X modifiers. Now, we can only append those to the column 2 codes that have the 1 superscript. Some of the codes do not allow any unbundling at all. And you would have to download the NCCI Excel spreadsheet to determine that. And there are proprietary programs that will tell you, if there's a column 1 or column 2, procedure to procedure edit, column 1 and column 2 code. And if they do have a 1 superscript that allows them to be broken out, okay? And of course, we don't use modifier 59 on E&M code. But your documentation must support a different session, different procedure, a different site, separate incision, separate lesion, separate injury. And that all has to be set forth in the documentation. Now, the X modifiers were developed by CMS back in 2015 to help reduce overpayment from what they were thinking they were getting gouged with 59 modifier, and thought they'd rein this in if they used the X modifier. And this is the definition of the 59 modifier, all these different things that would help qualify it. And this is the X modifiers, and basically they parallel each other. It is recommended that we use X modifiers, which is the XS or the XU for podiatry. We use the X modifiers because 59 modifier is the most scrutinized modifier there is. It's one that gets the most audits, etc. If you start using the X modifiers, at least some of the focus of attention will be taken off of you with the 59 modifier. Now, modifier 76, I put this in here for information. Basically, we do use these periodically. It is used on non-surgical procedure codes when you repeat a procedure. The same doctor is repeating. And it's mostly used for, let me give you an example, makes sense. You see a patient in the office, they got a displaced fracture, you anesthetize the toe or the metatarsal, you anesthetize the foot, and you close, reduce it, and then you take additional x-rays to see if your reduction is holding. So you're taking 2 sets of x-rays. So the first x-ray is billed as usual, 73630, but the second x-ray you need to do on a separate line item with the 76 modifier, telling the insurer that was a repeat procedure that was justified. Okay, and this is the one, modifier 78, unplanned return to the operating room by the same physician following the initial procedure for a related procedure. This is the other modifier that we would use versus 58 if we have to do another surgical procedure on the patient during the post-operative period. Now, it's used to tell the insurer that the second procedure that you're doing now is related and is due to a complication of that of the surgical procedure. Now, CMS has a slight different definition for complications and what's billable. CMS says the only thing billable during a global period, besides unrelated things, but anything that's related, the only thing you can bill for is if you take it back to the OR for another procedure. Whereas, let me get to this, and we'll talk about CPT. If you take the patient back in for a related procedure and use a 78 modifier, you will get paid the intra-op portion of the code only, which is about 69%, but it doesn't reset the global period. The 58 modifier reset the global period. So if you did a major procedure during a global period and use the 58 modifier, you start 90 days all over again. With modifier 78, wherever you're at with that original procedure is where you resume the global period after that second procedure. And as I mentioned, CMS and CPT different in their definition of complications. CMS, as I mentioned, says, unless you take it back to the OR, you're out of luck for billing us. CPT says if it's anything out of the ordinary, that's not the usual norm for postoperative care, then you can bill for that. The reason I'm mentioning that and why that's important is with private insurance. You should keep that in mind, that you don't have to take the patient back to the OR to bill for a complication. So if you have to drain a hematoma, a suture abscess, whatever it might be, that's the complication. If it's a Medicare patient, unless you take them to the OR, you can't bill them. If it's a private paid patient, I would bill them and I would use the 58 modifier for staged or related procedure for whatever you did, the IND or whatever it was that you had to do. And of course, if you take it back to the OR, you still have the option of using the 78 modifier. Again, some of this overlap that I was referring to earlier. And there's the breakdown that I was talking about, the intra portion. So we don't need to go through the example here. Okay, modifier 79, unrelated procedure. So during a global period, if you see the patient on one of those follow-up visits or even a newly scheduled visit for that condition, if they come in with something that's not related, so then you can bill for that and you would use this modifier, 79 modifier. And again, it has to be front related. So you're doing, you see, you've done a bunion procedure on a patient, you're seeing them back and they go, oh, by the way, doc, I have an infected ingrown toenail on my other foot. Okay, we're good with that. And you can bill for that using these 79 modifier on the procedure itself. And here is that example that I used. And of course, if you worked up the patient, did an E&M, then you can use the unrelated E&M modifier, which is 24, because it's an ingrown nail, not part of the bunion problem, and 25 because you did a workup on that patient, an E&M workup that was distinct from the procedure itself. Okay, modifier 80. This is one that we do use occasionally. That's for an assistant surgeon. Some codes qualify and the assistant surgeon can be paid. Medicare has a list of these procedures and other organizations and proprietary organizations also have lists of procedures that qualify for an assistant surgeon. So if you need another set of hands for that surgery and the other surgeon bills the 80 modifier, then they can get paid 16% of the fee schedule, what Medicare allows, and most privates are going to be somewhere between 16 and 20% for the assistant surgeon. But the main surgeon in his op report has to specify why he needed an assistant surgeon. And not just because he wanted someone to talk to during the surgery, because the other guy had nothing to do with his day off and he decided to join you in the procedure. We don't want that kind of misuse of that code. So there has to be some justification as to why you need someone other than the OR nurse. Now, I put modifier 95 in here just because this has to do with telemedicine, and it gives us the exception for using telemedicine services based on the exceptions that were made during the health epidemic that we just went through, the public health epidemic. And just to let you know that that it is a modifier that you would use on the code, on the E&M code, but make sure that if you do an audio and video visit with that patient, that you bill outpatient office E&M codes, and the place of service would be office. Do not use the POS of 2, excuse me, which is the originating site. We're not going to talk about that. What that means is that before the pandemic that we had, in order to do these telehealth services, the patient had to go to a very specific location, what they call the originating site. And there are other rules involving this. And you would put POS of 02 for that facility charge, so that facility can be paid, and so that you can be paid as well for that. But again, we won't get in that kind of detail on the modifier 95. We'll quickly talk about some CMS level 2 modifiers. When you use everybody knows the T codes here and these T modifiers, but you never use these on foot procedures. I see some people using them on foot procedures, and that's inappropriate, and we'll get your claim denied. And your ICD code should reflect the digital diagnosis. Same thing with RT and LT. You know, these are anatomical modifiers and can be used to bypass the NCI PTP edits. But when you, like for instance, use modifier 59, you would put it on the column 2 code, okay? But when you use these modifiers, you got to put it on both codes to let the payer know that the first code listed on the claim was on the right foot, the second code listed on that claim was on the left foot, and so that you can differentiate the different anatomical sites there. Same way with the T modifiers, depending on how many procedures you did, up to 10, you can use all the T modifiers, and I would use them on separate lines. Okay, the GW modifier, if you see someone in a hospice, you perform a procedure that's not related to the terminal condition, you can bill for that, but you use the GW modifier. And as a point, and in fact, I just got asked this question recently. Patient was on a Medicare Advantage plan. He went on hospice, and the office keeps billing the Medicare Advantage plan, and they're not getting paid. And the reason is, when a patient goes on hospice, if they are on a Medicare Advantage plan, and they go on hospice, they revert back to fee-for-service Medicare. They go back to original Medicare during the time that they're on hospice. So the G modifiers apply to CPT and DME codes. Now I put these modifiers on there again just to make sure that this slide deck was complete. We're not going to review these. Everybody knows the GA and hopefully the GY modifier. GY modifier is statutorily excluded services such as orthotics. But the patient needs a bill for secondary insurance. You bill L3000 for the GY modifier, let Medicare deny it, and still keep it on your patient liability so you can bill their second insurance for that. Let me see, I got to go back one. Hang on a second, I skipped one. Let me go back to previous. Okay, I'll tell you what, I'm having technical difficulty and times going by. So the JW modifier is modifier that a lot of us know about when we are using CTPs, skin substitute, and it indicates the amount wasted. So if you have a 44 square centimeter wound, you use 30 square centimeter of the product and you waste 14 square centimeter, you've got to indicate that on the claim form, and you use the JW modifier on the part that was wasted. Now, beginning July 1st is a JZ modifier that's going to be applicable, and for us, it'll involve skin subs. So that if you have a 44 square centimeter wound and you use a 44 square centimeter skin sub, that's how it came, and you put the whole thing on the wound, then you have to tell Medicare and the private payers that you use the entire product, there was no wastage, and that's how they know that there was none wasted, and you would use the JZ modifier. Currently at APMA, we're trying to get some clarification on this, because the way we read that is that the JZ modifier should not apply to skin subs, and yet different MACs are telling us yes they do, and other MACs are telling us no they don't. But in the meantime, since CMS came out with this, we recommend using it until we get this straightened out. Okay, DME modifiers. There's basically two main ones, and that is the KX, which says that everything that's required in the policy or the LCD was done, it's medically necessary, and you're telling them that, and that's why we want you to pay this. Now, when providers put that KX modifier on an orthotic code, a foot orthotic code, Medicare is going to pay you for that orthotic. It's not right, and when you get audited, you're going to get nailed big time. We've been preaching to people for years and years, do not use the KX modifier on foot orthotics and bill Medicare for that. And also the LTRT. When you do bilateral AFOs, for instance, you have to do them on single lines on the claim form, and you have to not only use the KX modifier, but on one line, use the LT, the other line, you use the RT. And if you do not use both of those modifiers, your claim is going to be denied by the DME carrier. In our case in Iowa, that's Meridian. Okay, now, when it comes to AFO modifiers, they can be in any order. You can put the LT first, or you can put the KX first, it doesn't matter. In the past, it did. But the DME MACs have changed that so you can apply it in any order that you want. Wound dressings, for those who dispense out of your office, A1 through A9 indicates that it's a primary or secondary dressing, and it indicates the number of wounds the dressing is going to be used on. Not the number of wounds the patient has, and not how often they're doing it, but actually the number of wounds that particular dressing is going to be used. And you may be using different dressings for different wounds, and that's fine. They each have to be on a separate line, and you would use the A1 through the A9 modifiers. Now, the FX modifier is applied to X-ray for those doing plain film X-rays in your office, and it's just a reduction. You have to put this on the code, 73620 or 30, whatever it might be. You would put the FX modifier, and that tells Medicare or the Medicare Advantage plan that you have to reduce the technical component by 20%. Since 2017. Okay. Now, then they added another one the next year for the CR, computed radiography, which is still a cassette-based imaging that utilizes an imaging plate to create the digital image, and it's not a direct digital image. It's more or less indirect. And Medicare is going to nail you for that, like the Medicare Advantage plans are. And it had been 7% for the technical component until this year when it jumped up to 10%. Now, Medicare modifier definition may be different than CPT. Usually Medicare and CPT do line up in their use of modifiers, but Medicare's definition of the global package is different than CPT, as I mentioned, with complication, and the fact that if you have a complication and they're privately insured, you should bill for that complication, okay? If it's something that you've done in the office, or even if you take it back to the OR. But remember, Medicare says unless you take it back to the OR during the global period, you can't bill for related procedure. And add-on codes are not to be confused with a bilateral procedure or the multiple procedure modifiers. And when using multiple modifiers, always put the pricing modifier before the informational modifier. Otherwise, your claim can get kicked out if they don't see that pricing modifier, like the -24, the -59. tell them that, yeah, I mean for this code to be built. It's not part of the global. It's not related to what I've done before. And they have to have that or the computer is likely to kick it out. And I will mention something about the 25 modifier with Medicare. If it's a new patient and you do an E&M and a procedure, technically speaking, you do not need the 25 modifier on that new patient E&M code. Now, an established patient, yes, with Medicare, but not on the new patient. New patient with private payers, you bet you want to use the 25 modifier. Now, if you use the 25 modifier on a new Medicare patient, it's okay. They'll still pay it. My point is you don't have to from a technical standpoint. And to finish up on this, if you have any ideas on subject matter for any of these subsequent type of webinars for new practitioners, submit that to Kevin Cruz at IPMS. And I've given a few suggestions, but there are also financial ones that you can consider: student loans, getting started in practice, planning your financial strategy for your career, and other such things that are applicable. It doesn't have to be just coding or medically related either. And so with that, we've completed this modifier maze, and sorry it took a little bit longer, so we're going to get shortchanged on our Q&A. But any questions that I don't answer during the Q&A session, we will answer afterwards, and we'll get that posted and disseminated to you. So I want to thank everybody for attending this on a Tuesday night, and hopefully you've learned a few little pearls. As I've always said with any lecture I've gone to, if I can learn one little pearl from a lecture or webinar, then it's been worth my time. So thanks, everybody. And I think, Kelsey, I'll turn it back over to you for the questions.
Yeah, it looks like we have a few in the chat box here. So I'll start with the first one. E&M based on time and using 99215 or 99205 with either G2212 or 99417. Should the 99215 or 99205 have the 25 modifier?
Okay. Yes, it's the 99205 or 99215. That's the one that's going to require that. Those modifiers were developed for those codes. Well, other codes as well, but strictly for your question, for those codes.
And then the next one says, given multiple procedures performed in a given visit and either 11720 or 11721 performed, then are 11720 and 11721 always considered column 2 codes regardless of the other procedure?
Not necessarily. Now, okay, what the question is, are the nail debridement codes always column 2 codes under the NCCI? They are if you do callus debridement at the same visit, but that doesn't mean that if you do something else and the nail, let's say you do an injection and you do the nail care, I'd have to look it up to tell you which is going to be the column 2 code, the injection, which I would guess would be, but I don't know for sure. So you have to look up in the NCCI tables, which is the column 2 code. Oh, by the way, the APMA Coding Resource Center that a lot of us subscribe to has a very easy NCCI where you put in 2 codes and it'll tell you if they've got an edit and which is the column 1 and which is the column 2. But there's other proprietary programs. And if you go to the CMS website, cms.gov, and find the NCCI, that table's for free. It's an Excel spreadsheet. It takes a little bit of time to scroll through to find the code, but it's doable and it's free. And so the answer to that question is, it depends on what the other code is. So 11720 and 21 might be the column 1 code. And yet in other instances, it may be the column 2 code.
The next question is for UHC dual complete. Should ×2 or the X2 or X4 modifiers be used?
I'm sorry, could you read the last part of that question? I didn't quite hear that.
Should the X2 or X4 modifiers be used for UHC dual complete?
X2. I guess I'm not sure what that's referring to. X2.
I don't know. Or ×2?
Maybe, okay, so read that question with the word times in it, and let's see if that makes more sense. I'm sorry about that.
No, it's okay. Sorry. For UHC dual complete, should ×2 or ×4 modifiers be used?
Okay, I guess I still don't understand it, but if whoever wrote that question, if you could resubmit that, maybe with a little bit of explanation for me to understand. Again, I apologize for not understanding what the question means. The dual complete tells me that they're a Medi plan, as we used to call that, a Medicare and Medicaid. But past that point, I'm not sure what X2 and X4 is referring to.
The person said that would be the patient relationship codes.
Oh, okay. That I'm not familiar enough to really provide an answer to that. But you know what, Kelsey, hang on to that question, and afterwards, let's see if I can make some sense out of this and post a response to that.
Okay. And then someone wanted clarification for procedures on a patient enrolled in hospice and given Medicare Advantage. Is Medicare Advantage the primary then? Sorry.
Oh, yes, Medicare.
Should GW not be used?
GW cannot be used with Medicare Advantage plans, because here's the thing, even though that patient might be on Medicare Advantage, once they elect hospice, they automatically go on regular Medicare. Okay, so yes, you can submit claims, but the GW, they're not going to pay it. Why? Because the patient's on regular, the Medicare Advantage plan is not going to pay it, because the patient's back on a regular Medicare and regular, and which includes DME as well. So while they're on hospice, if they need diabetic shoes, for instance, you would bill Meridian, and you would not bill the Medicare Advantage plan. You would use the GW modifier in your first position. And then you would use the KX and the LTRT, you know, that kind of a thing. Again, order matters in a lot of cases. But DME says they don't care what order they're in, so they take care of that problem for you. But other payers, it would matter. Okay. Now, again, when a patient goes back, when they go on hospital, they go on regular Medicare. You would submit your claims to regular Medicare with the GW modifier. Now, if they're taken off of hospice because their condition changed and now they're no longer under a life-threatening situation, that's meaning then they're not going to be deceased within a year, then they can choose to elect to go back on their Medicare Advantage plan at that point, and everything will pick up where it left off before the initial hospice episode. I hope that's not confusing. Okay.
And then it looks like we have one more. So for Iowa MCOs for DME, including therapeutic shoes, do you recommend using KX and RT-LT modifiers?
Yes. Yeah. Just because this is a Medicare thing and Medicare likes to do it that way, a lot of the private payers like to do it as well. Even the managed care organizations, whether they're managing Medicaid or Medicare, because most of them are going to go by Medicare's rules. Even Title 19 in Iowa will tell you that we unless we have our own policy, we go by Medicare's rules on whatever it is that's being treated. And the Medicare Advantage plans, they use that as an excuse a lot of times to try to deny payment. Hey, Medicare says we shouldn't pay for this or that because there's a procedure to procedure edit, and that's why you got the claim denied. They're going to look for every excuse not to pay you. And so they're going to use Medicare's rules and regulations, which are very strict in a lot of cases. So yes, whatever you do for Medicare, I always did for the private pays, unless it proved to be something that caused a non-payment or a denial. And in that case, that isolated case, we just made note of it. And next time that happened, we just didn't do it the same way for that private payer. But in most cases, you're going to be fine. Anything else, Kelsey?
So the person talking about the patient relationship codes, it looks like the X2 would be connected with a long-term diagnosis attached, and the X4 for a short-term treatable diagnosis attached for given procedures.
Okay, and that's something that I'm going to need to look into the policies governing those two designations and what they include or exclude before I could answer that. And again, I apologize for that.
I think that looks like all the questions. So thank you,
Okay.
Dr. Ann.
You're welcome. And the last thing I'll mention, if anybody thinks of any questions at the termination, which is going to be now, or any second now, go ahead and submit your questions either to me directly or through IPMS. If you do through IPMS, then we will be able to publish the question and the response as well. So if you think about something later, go ahead and hit us up and we'll be happy to take care of that for you.